Good morning, Dato, Dating, professors, doctors, and colleagues. I'm tasked to introduce the second speaker today. It's my colleague, Dr. Ridwan. He graduated with MBBS from University of Malaya in 2004 and then continued his education in surgery with Master of Surgery from his alma mater here. He is a proactive clinician, mainly involved in microsurgery and reconstructive surgery. His latest quest is to introduce and expand the understanding of super microsurgery in the Malaysian medical fraternity, especially in the management of lymphedema. Ladies and gentlemen, I welcome Dr. Rizwan to give his talk.
Thank you so much, Hong. Assalamualaikum and a very good morning to professors, Datuk Datin, doctors, fellow colleagues, ladies and gentlemen. Thank you, Dr. Kong Chee Kwan, my colleague in the Division of Plastic and Reconstructive Surgery, for the kind introduction. I would like to thank the faculty for giving me the opportunity to share some of my daily work in this platform and currently one of the latest development in our division's forte at the moment. So, lymphedema is a disease which is familiar to many of us, but many of us do not know the subsequent management of this condition. So today in this platform, prestigious platform, Breakfast at UMHealth, I would like to share some of the management of lymphedema, and topic of the talk would be the swollen truth, unpacking the latest management of lymphedema. Okay, please allow me to share my slides. Okay, again, sorry, my topic will be the swollen truth, unpacking the latest management of lymphedema. So as we know, during our medical school days, we were taught that there's three types of vessels in the body, which is the artery, the vein, and of course the lymphatics. And as we all know and quite familiar, about diseases of the artery and the veins and how to manage these conditions. However, we are actually not very well versed in the management of patients with lymphedema. So as we know, during our medical school days, we were taught that there are functions of the lymphatic system. Number one, it actually drains excess tissue fluid, and in a certain things that is actually maintaining fluid balance in the periphery. Number two is also functions in immunity, in immune defense, because it filters the pathogen and also house the immune cells such as lymphocytes. Besides that, it also help in the transport of waste, carries byproducts from the tissue to the lymph nodes and eventually to the general circulation to be processed accordingly. And of course, the last but not least, in the gut, the lymphatic actually helps in fat absorption. So when there is excess in the lymphatic fluid accumulation due to either destruction of the continuity of the lymphatic system or an obstruction, this will lead to the development of lymphedema. So lymphedema is a chronic and debilitating disease that disrupts the lymphatic channel, okay, resulting in fluid retention within the institution. It is a progressive disease, and previous treatments have not been achieving real cure. So the progressive lymph flow obstruction actually induces severe lymphosclerosis. So generally we can classify the lymphedema based on the etiology and on the location. So the classification based on etiology can be divided into primary and secondary. Primary usually happens without any, it happens because of abnormality of the lymphatic channels themselves. So usually if it happens below the age of 1 year of age, we call it a congenital lymphedema. If it occurs about the age of about 1 to 35 years of age, we call it precox. And if it's more than age of 35, we call it tarda. And this usually without any precipitating factors. Now, secondary lymphedema is caused by either lymphatic obstruction or lymphatic interruption. Lymphatic system obstruction could be caused by either malignancy, infection, or radiotherapy, while the interruption is due to removal of lymph node in malignant cases, in management of surgical management of malignancy cases. All right. It also can this lymphatic interruption also can be due to traumatic events, or also could be due to parasitic infection. All right. And then this recurrent infection, for example, cellulitis or erysipelas, also can actually cause sclerosis of the lymphatic channels and cause lymphatic obstruction, which is part of the secondary lymphedema, formation of secondary lymphedema. So when we actually already identify what is the cause, based on the history, whether it's due to primary or secondary causes, then we can classify it according to location. So whether it is involving the upper limbs, lower limbs, below knee or up. So we have to document whether it's below the knee or the swelling is up to the thigh region. And also if it's involving the genitalia, either the vulva or scrotum in male. So now we will talk about the pathophysiology of the lymphatic channels. So when there is a reduced, in the initial stage, when there's a reduced lymphatic transport capacity, like mentioned earlier, either due to an obstruction or due to discontinuity of the lymphatic system, this can actually cause the accumulation of protein-rich interstitial fluid. So usually in the initial stage, patient will present with swelling, which either could be swelling due to after prolonged episodes of standing, or which and usually will resolve on its own by lying down. Or number two is also could be due also could and usually the edema is pitting in nature and usually will resolve when the patient is lying down and it is gravity dependent. All right. So when the patient lift up the leg and lying down, usually the lymphedema will subside. Then it will go to the next stage, which is inflammation, fibrosis, and tissue remodeling. So due to the accumulation of these lymphatics in the third space, it actually because one of the function of the lymphatic channels is actually to remove all these byproducts of infection or byproducts of cytokines or inflammation. So this will actually stimulate further inflammation and will attract more immune response. So this will encourage migration of inflammatory mediators and also immediate secretion of inflammatory mediators by inflammatory cells, and this will stimulate formation of fibrosis. And this formation of fibrosis would, because of this inflammation, both inflammation and the stimulation of fibrosis, which will further compromise on the lymphatic function. And during this time, during the second stage, you will notice that the patients will have some form of non-pitting, will starting to have non-pitting edema, but the swelling still could be resolved after elevation of the lower limbs. And during this time, usually the patient would have some form of skin due to prolonged swelling. Sometimes what happens is that there is reduced blood supply or capillary blood supply to the skin, and the patient would have some form of atrophy and sometimes scaly skin, and also at times the patient can develop cracking of the skin, which will introduce infection. Infection can go into this dry, scaly skin. And if this infection will stimulate further inflammation and later on will cause further fibrosis and will actually worsen the lymphedema. And hence, this actually explains the clinical progression and the tissue changes by which in the initial stage, the patient will have pitting edema and reversal swelling. And in later stages, the patient will have non-pitting edema, skin changes, and also further increased susceptibility to infection and lymphangiectasia. All right. So this is the diagram that have been shown. And due to excessive accumulation of fluid in the third space will actually cause further fibrosis and worsen the condition. Now, the staging. Staging of lymphedema can be divided. It has been formalized by the International Society of Lymphedema Staging. As we know, it's staging is for the ease of communication and also for ease of classifying the management. So the initially we can classify the patient as having stage 0 if the patient do not have severe symptoms, which is considered as subclinical lymphedema without edema, but evidenced by of impaired lymphatic function. So usually this can exist months or years before overt edema occurs. And sometimes these patients are, for example, patients who had surgery or radiotherapy to the either axillary or inguinal lymph nodes. So the patient will have some heaviness, but clinically they do not have symptoms of, so there's clinical signs to suggest lymphedema. Now, when the patient was started to have some form of edema, which is pitting, and usually it is reversible and the size could go back to normal, this is actually classified as stage 1 and could be and if the progression is not halted, it become stage 2A, by which pitting edema is not reduced by elevation, and 2B if the non-pitting edema is secondary to pronounced fibrosis. In stage 3, there will be lymphostatic elephantiasis, by which there is progressive fibrosis and the skin changes, prominent skin changes in the form of acanthosis, hyperkeratosis, and papillomatosis or warty growth. This is the classification by the International Society of Lymphology. As we can see in this picture on the right-hand side, we can actually see the differences, all right? The left-hand side is some form of swelling, but usually the swelling will reduce on its own or not very significantly impairing, causing impact lifestyle to the patient, and it can be considered as stage 1. The second picture is 2A when there is some pitting edema, and 2B if non-pitting edema with some pronounced fibrosis. There is some firmness in the palpation when you palpate the leg. All right. Stage 3 means there's some lymphostatic elephantiasis, as in changes, marked changes in the shape of the leg and also with some skin changes. No, investigations. But the gold standard for diagnosis of lymphedema is radionuclide lymphoscintigraphy. Usually you can diagnose it clinically, all right? But to demonstrate the edema, the lymphedema, because sometimes, if it's unilateral, most of the time we can actually say quite confidently that it is actually lymphedema. However, sometimes the lymphedema are bilateral. So to actually get a proper diagnosis, the gold standard to confirm there is some issues with the lymphatic system or lymphatic drainage is actually doing a radionuclide lymphoscintigraphy. Is currently considered as the gold standard. It actually can assess the function of the lymphatic channels and drainage of the lymph to the nodal basin. So it can actually also ascertain the severity of the lymphedema and the level of obstruction. So for example, if the obstruction is actually at the knee level, you can actually see that there is some slow movement of the injected radionuclide proximally. So however, there's downside for this imaging. The images, number one, the images produced is sometimes poor or of poor quality and offer limited anatomical detail. These images can only show which level and the severity, but it cannot tell you which lymphatic vessel can be used for the management later on that we will discuss. All right, and number two, it also you need some time actually. Like for example, the picture on the right hand side, the imaging, the lymphoscintigraphy, you can actually see there is some flow, obstruction of flow after injecting 5 minutes, and and more prominent at 4 hours, and they do every 15 minutes, and after that 1 hourly. You notice that there is on the left foot there is almost clear radionuclide as opposed to the lower limb. So we can actually, and the level of obstruction is actually quite distal. All right, it's actually at the leg region here. Okay, so but it doesn't give us any anatomical input at which vessels can be used for the further management later. So that's why people are moving towards magnetic resonance lymphangiography, by which it actually gives us a superior high resolution anatomical images of the lymphatic system, and actually can give a detailed characterization of the soft tissue changes associated with lymphedema, which is important in localization for surgical planning. So usually we do this way before, and in centers who are actually actively doing lymphedema surgery, they actually go away with, they don't do lymphoscintigraphy anymore. They move towards magnetic resonance lymphangiography. And if you can see in this diagram, they can actually see, you can actually see that the pointers are actually pointing which vessels are, lymphatic vessels are affected. All right. So this actually can be used so they can actually identify which lymphatic vessels can be used for the surgical management. Now, for management, usually we will proceed with we call it a complete decongestive therapy. That means, in a sense, it's a conservative therapy. So what we do is that we refer the patient to physiotherapists. The physiotherapists will do manual lymphatic drainage. That's a fancy name for massage lah, basically. Manual lymphatic drainage just means massage. Okay, and of course, compression bandaging. That means the patient have to have some form of a bandage. The limb which is affected has to be bandaged, and is taught how to do skincare, proper skincare, because as I mentioned, the skin could be dry and could crack and introduce infection, and can cause worsening of the lymphedema. So the patient is being taught how to take care of the skin. And of course, the patient will also be taught on how to do exercises. This is very important because when the pumping of the muscle will actually helps in pumping the lymphatic proximally. All right, because of with the help, of course, with the compression bandaging, in tandem with the compression bandaging, the patient have to do the exercises with the appropriate compression bandaging. Exercises without compression bandaging would not help, because the muscle will be pushing against the pressure from the bandage, and this will help in pushing the fluid proximally. And of course, education and when to, what to do and everything. So usually, then it will progress to after about a month or 2 months, when the physiotherapist has been working with the patient in close contact. Then when the patient has confidence in managing themselves at home, they can do the proper massaging of the limb, and also appropriate. They know how to do the compression bandaging. Then the patient can actually do it at home, and we call this as the maintenance treatment, which is actually self-care. All right. And certain patients we suggested for a pneumatic pump, which is actually is a pump, a machine that will actually help in doing the massage, the manual lymphatic drainage, because usually you need some person to actually massage the leg from distal to proximal to actually to help with the drainage of the lymphatic fluid. However, if you have the machine, it will actually help in pumping the fluid proximally. And of course, weight reduction, because sometimes these patients because they are unable to move and unable to be active, we will suggest the patient to have some form of weight reduction, that which actually will help in reduction of the pressure towards the lymphatic drainage. All right, and actually studies have shown that it's actually improved in the outcome of the complete decongestive therapy. So usually during the maintenance treatment, the physiotherapist will see the patient regularly, probably a month or once a month, actually, and to monitor the outcome. If the outcome, that means if the patient has no changes after 6 months of therapy, then we will proceed with some form of surgical intervention, which can be divided into two: either physiological procedure or ablative procedure, depending on what type of ISL stage that I mentioned earlier. So some of the physiologic procedure that we can do are, number one, lymphaticovenous anastomosis, LVA, or lymphaticovenous bypass, LVB. It's the same thing, all right? It's just different in name. Some people call it LVA, some people call it LVB. And the second surgery that we can do is actually vascularized lymph node transfer. And I will explain these two procedures later and in which condition we actually do this physiologic procedure. Another surgery that we can do is ablative surgery, which is what the previously was done back in 10, 20, or 30 years ago. So that will include liposuction or debulking surgery, such as Homan's procedure or Child's procedure. This will actually include removal of part of the skin, part of the subcutaneous tissue and skin grafting. So this is a very debilitating surgery that which a lot of center in the world, if done properly, if the patient has undergone complete decongestive therapy and properly, could just proceed with physiologic procedure without going for an ablative surgery. But you have to have a very good physiotherapist to help with to actually change whether the patient can go for a physiologic procedure. Now, this is a flow chart on the management of symptomatic lymphedema, which is being in one of the centers in the UK. So they've mentioned whether the patient, first of all, amenable to physiologic procedure. If yes, so the patient is sent for the complete decongestive therapy, and when the symptoms plateau or worsening with significant pitting edema, and then after MR lymphangiogram, then proceed. And the next question will be whether the patient had whether it's secondary to surgery or radiotherapy, then we can proceed whether to do a lymphovenous anastomosis or vascular lymph node transfer. With an adequate response, you can do another cycle of either LVA or VLNT, or if not, then proceed with liposuction and incision. If the patient has no or minimal or no improvement with non-surgical therapy, with severe functional impairment, no excess, with a lot of excess tissue, then the surgery will be ablative. Okay, so this is one of the flow chart of management. So it's very simplified. Okay, so for the physiologic procedure, which is lymphaticovenous anastomosis and bypass, it will actually involve super microsurgery. So I just want to talk a little bit about history of super microsurgery. It's no longer just microsurgery. We're talking about super microsurgery. So in 1987, Taylor and Palmer actually mapped the angiosomes in the body. That means they actually identify the blood supply to each of the skin, the perforators. And it means the smallest blood supply from the artery and this corresponding vein. So due to this concept, in 1989, Professor Koshima from Japan actually reported the first free flap-based perforating vessels, which using the deep inferior epigastric perforator flap, which is a very popular flap to reconstruct the breast for plastic surgeons. All right. So this will involve some form of microsurgery. Now, this procedure required careful dissection of the perforating vessels through the rectus abdominis muscle. And because you need to dissect the muscle, it will take some time. So to reduce the time to dissect the vessels, Koshima actually designed flap based on smaller and more distal vessels. And these vessels are between 0.8 and 0.3 centimeter in diameter. So what is super microsurgery? So definition is an anastomosis of vessels smaller than 0.8 millimeter in diameter. So initially done for the treatment of lymphedema. So the treatment of lymphedema consists of lymphovenous anastomosis that I mentioned earlier. So how do actually this work is when you bypass. Okay, that's why some people call it LVB. So drainage of the high pressure lymphatic, which is dilated, to the superficial veins. All right, I will show some diagrams later. Number two is you can do a vascularized lymph node transfer. How does this help? the mechanism is actually to bridge the bridging lymphangiogenesis, because the postulation is that when you put a lymph nodes, a tissue with a surviving lymph node, this lymph node will actually will actually grow lymphatic channels to the nearest lymphatic channels. They will try to find and connect the lymphatic channels. And also the pumping action driven, the perfusion gradients between arterial inflow and venous outflow. That means it will actually stimulate, because of this anastomosis between the artery and vein of the vascularized lymph node. This will actually promote the growth of the lymphatic channels. And the last one is the vascularized lymph vessel transfer. That means we actually transfer a tissue together with a intact lymphatic channel, and we actually put it in, we actually move it to a part of the body which has the lymphedema, and this will actually grow. Like the principle is similar with the vascular lymph node transfer, in the sense that the lymphatic channel will grow to the nearest lymphatic channels. Now, so the preoperative planning is we have to have a superficial high frequency ultrasound is to identify the superficial vein and dilated lymphatic channels. So this is the ultrasound that we have to use it. We have to do it the day before operation. Okay. So there is two types of. This is actually, this diagram is showing whatever ultrasound picture that is visible on the left hand side. And you can see the superficial one, when you actually put a pressure compression, both of them actually compress, but more so in the superficial vein. Okay, all right. So more so in the superficial vein, and we must mark these areas, the skin at the lymphatic and also the venous part. And we also do a indocyanine green lymphography, by which we inject indocyanine green distally, and then we put a red light, and then see through a screen, and then we can actually see the flow of the ICG proximally, and we can identify the lymphatic channel which is involved. And this is what I mentioned earlier. We identify the lymphatic channel, all right, and these are the veins, the superficial veins. So which area that is is near to each other, we make an incision and anastomose between the lymphatic and the superficial veins. And this is a post-operative picture. Okay, so this is what I mentioned after identification. So with these two modality, the ultrasound and also the ICG, we identify. So in this picture, the first picture, you can actually see the superficial vein. All right, and this is actually the lower part, the whitish colored tissue is actually the vein, and you identify it and you cut it. All right, all right, and then you approximate it and anastomose. So this is what we call a super microsurgery. This is very small. This is less than 1 millimeter, 0.8 millimeter. Okay, so this has to be. We have to do this. We need a microscope, a very high resolution microscope to actually do this procedure. Now that's for LVA, and I'm talking about vascularized lymph node transfer. Just to be briefly, for example, in patients who had left axillary lymph node excision for either breast cancer or other upper limb malignancy. So what we can do is actually harvest lymph nodes, all right, and we actually anastomose. So we just take the artery and vein and the tissue together with the lymph nodes, and we just anastomose the artery and vein and just put the tissue there. So what will happen, this lymph node will actually grow towards the nearest lymphatic channel and will establish the lymphatic flow. All right, another place that we can actually harvest is actually from the omentum. Like, for example, in this case, we can actually take the gastroepoploid artery together with the part of the omentum, which has a very rich supply of lymph nodes. Okay, and then we just anastomose the artery and vein to make this tissue viable, and the lymph nodes will actually find the nearest tissue. All right, for example, in the leg or the upper limb, will actually grow towards it to actually form a connection, to complete the connection between the lymphatic channels. This is the third method, which is the vascularized lymph vessels. This is a little bit more out there in the sense that we have to do the ICG and identify the lymphatic channels that I mentioned to you earlier. Then we can harvest the flap together with the lymph vessel, with the arterial and vein. So what we do is that we identify the lower limb with the ICG and where is the defect of the lymphatic drainage, and we do the arterial and venous anastomosis with the same direction of lymphatic flow, and this hopefully will grow into the abnormal lymphatic channel and will actually complete, okay, the abnormal limb with the flap. The lymphatic will actually grow towards each other and will actually drain they will actually help to drain the lymphatic the lymphedema basically. So other applications of venous anastomosis besides lymphedema, like for example, the management of chylothorax, if we route the leaking lymphatic fluid or chyle from the thoracic duct into the vein to stop the fluid build up in the chest. Same with chyloascites as well, especially most of the time it's managed conservatively, but if it's resistant after 1 month or 2 months, there is still chylothorax or chyloascites, something that we can think about is to drain these lymphatic channels towards the nearest vein, okay? And another development of lymphovenous anastomosis is actually in the management of dementia, especially Alzheimer, because the postulation that is that the Alzheimer is due to formation of protein buildup in the brain. So if we can actually drain this protein-rich environment, actually improve in the reduce the formation. We can actually reduce the rate of Alzheimer's. So this is the postulation to improve ways of amyloid beta clearance. Okay, so I think I've already given a lot to talk about, and it's actually more to introduce the service that we are actually starting very soon. Okay, and I would like to thank everyone for listening and for coming to my talk. And I would continue. I would invite Dr. Kong to say something, Dr. Kong.
Thank you, Dr. Ridwan, for introducing and explaining the management of lymphedema. Is there any question from the audience? I don't see any question in the chat box yet. Sorry, there is a question from an attendee. Thank you for the fascinating insights and updates on approach. A few questions. Number one, who are the local very good physiotherapists who may offer CDT available in UMC? Maybe Dr. Rizal can answer the first question first.
Okay, so we have dedicated physiotherapists. We actually they are actually actively managing for patients with breast cancer. I think a lot of patients with breast cancer and the breast team has been referring to these physiotherapists. They're very good actually in our center, but probably I think the upper limb one, they are very well versed, but probably the lower limb, especially the very bad ones, in stage 3 ISL that I mentioned earlier, those are not, we haven't gone into like a proper discussion yet. But generally, the stage 1, 2, there's not an issue at all. And for the upper limbs, usually it's very rarely the patient will progress to stage 3. So I would say yes, but at the moment we have to improve on the what do you call that, the delivery of services, like especially in stage 3, like the advanced stage. Yeah.
Okay,
And
thank you, Rizal, for the answer.
and the
So
second
have you finished answer? You can answer the second
Okay, so yeah, because we
question.
have another 3 more minutes. Breast cancer, axillary lymph node dissection of gynae tumors with pelvic nodal disease are surgical options typically offered, LVA or VLNT, VT. Actually, that's why we just started the services. So we are actually bringing all the instruments and items, and we are actually starting to offer these services this year onwards. So actually, if you have cases, you're more than welcome to actually have a discussion, so we can actually plan. Because usually the patients will undergone axillary dissection, usually 30%, 20 to 30%, we have some form of lymphedema, while lower limb gynecological procedures, especially if you remove the pelvic lymph nodes and all, in the literature says about 50 to about 60% development of lymphedema. Probably majority of them in the earlier stage. All right. So I think we welcome referral of cases. Probably we are also quite new in this territory, so I think discussion would. I mean, it wouldn't hurt lah. Basically, it is not an issue at the moment. So, but I actually have to warn you also that our clinic now probably we have 30 patients for general plastic, and at least 4 or 5 of them will be lymphedema patients. So that be occupying about 20 to about 15 to about 20% of our clinic load at the moment. So there's another question by Prof. David Oregon. What size of needles are you using? And how about training surgeons to do this fine work? Okay, thank you, Prof. David. So the size of needles that we use are 11O and 12O. How about you go training the surgeons? Actually, there is the company, there is courses actually in overseas. One of the center that actually do this training is actually in with Prof. Koshima, Prof. Isao Koshima himself in Hiroshima, and you can actually visit him for 2 weeks to do the training. Number one, and number two is they actually sell the set. And actually, if you are interested to know about this, I actually we bought the set, and if you're interested to know, we can actually share with you I mean for you to have a look at the sets and training sets, and also the what we call it, the lymphatics, which is a mimic they mimic a lymphatic using silicone. And I think it's already 9 o'clock, huh? Thank you, Prof.
Yes. Thank you for the questions. And then I think we have reached the time, 9 o'clock. So we thank you, Dr. Ridwan, for his wonderful presentation and the enlightening lecture. Any further question? If not, I would like to end this session. Dr. Ridwan, do you have anything to say before we end this session today?
I think I thank the faculty and also for giving this opportunity to give a talk. And also thank you, Dr. Kong, for introducing me today. Thank you so much.
Okay, thank you. Goodbye.